Hi, it's Shirley Gutkowski from Primal Air, and I thought this was a very interesting case that I thought it would be fun to share and to kind of watch how we had to make all these ping pong ball, maybe not ping pong ball, kind of moves, pinball. That's the word. We had to make all of these different moves throughout his entire treatment plan. We're not finished, but I think this is interesting for everyone to have a little look. So this is Matt. This is about Matt and his desire for more options than just a CPAP. So we're going to go over some of my original findings. I'm not going into a lot of detail in everything because I think this is going to be close to a half an hour, so I don't want to make it any longer. So I saw him originally in June. He was given a CPAP because he had symptoms of sleep apnea, and he went to the doctor and said, yes, you do have sleep apnea. Here's your CPAP, and just make sure you wear it every night. And so he did wear it every night for 4 months and pretty much threw it out the window. So about 50% of people will want to throw away his or their CPAP machine, and 50% love it. So you just never know what you're going to get. So he did not like it. He found the book Breath by James Nestor, and he started to look for a myofunctional therapist, which is how he found me. And so we did our intake, and this was my little treatment plan. We did not have a CBCT. He did not have a sleep study to share with me. And yes, he did. He did share the sleep study. We didn't have to do a sleep study, but we do monitor our sleep patients with the circle ring. The circle ring is an oxygen monitor that's continuous for the whole night. So we get a lot of really good data from the circle ring. It's almost better than a sleep study, to tell you the truth. Plus, we get, updates every morning on how everything went. He did have high blood pressure listed, and he made a comment about it on his health history, and so I suggested that he may want to do a calcium heart scan, which I found to be very effective in at least letting people know what their risk was, what the true risk was for heart attack, or cardiovascular event, I guess is a better way to say it. There's another blood test that I think we may be adding into our treatment protocols or our data gathering protocols, which is called plaque-2. And so that tells you if there are enzymes in the blood that are present only when a plaque is on its way to rupturing. So I don't know. For right now, see, the CBCT, sleep study, and the circle ring are primaries. And then we've got stuff that's, I don't know, do you want to call it out of the scope of practice? I don't know how I want to even say it, because we all know a lot of things, and if we don't help our patients at least seek out some of these other things, I don't know if this is a really a good plan. So when I do a treatment, not a treatment, when I do a findings report, I do have a treatment table. And we had recommended, without the CBCT and without the circle ring monitoring so far, he did present with what looked to be a tongue tie. So we recommended a functional frenuloplasty and the AOMT protocol, which is a loose, I don't know, Joy said it best. She says it's like a lasagna recipe. So we work on uh, a treatment plan that is pre-written, and then we massage it as we go along. So we're looking at hyperventilation, and we want to make sure that the tongue is in the right position. We improve nasal breathing and labial occlusion. as well as lingual occlusion, and reduce and eliminate sleep apnea to make it be possible for him to live his life. He had a pretty narrow palate, and so I was really anxious to see what difference or what the x-ray was going to show. It did take him a long time to get me the x-ray. So we started myofunctional therapy in June. He had a Mallampati score of 4. So I imagined, as pretty much all of us do, that his airway was very compromised. We had problems getting the sleep study results sent to me. Actually, he couldn't even get them out of the hospital. He's had every problem you can imagine with just paperwork and care. Because of his severe allergies and the amount of trouble he had breathing through his nose, he discovered something called Advent Nose, which is an ENT outfit that works only with people with sleep apnea. So he had his Advent Nose initial assessment. They also wanted to do a CBCT, and yeah, everybody has their own hurdles. I'll take anybody's CBCT. I don't care who took it, so long as they don't use a tongue or a peg in the front and a chin rest. I do have standards, but they're pretty fluid. Then he had a car accident around December, and the head CT that they took found calcifications. And then they had also recommended, woohoo, a calcium heart scan. So that was fun to hear. But his A1C was a 9. Now we want A1C to be under 6. Anything over 6 is pre-diabetes, and anything, I don't even know what, 7, I think. Yes, 7. A1C is the measurement of glucose attached onto your red blood cells over 3 months' time. So his A1C was 9, and if you do the big calculations, his blood glucose was probably normally in the 300s. Now, that should also show on a sleep study. So we'll see if we get to the sleep study if I remember to point it out. So I still hadn't seen a CBCT. And so finally in December or so, I finally get some CBCT stills that I request from the doctor who's doing the scan. And I would like to have the crosshairs on the sagittal view at about the second premolar of the upper arch. And then on the axial view, I would like to have that center line split 8 and tooth numbers 8 and 9. And that gives me 3 really good generic kind of views. The x-ray was read by beam readers, and then there was a little bit of a glitch between the doctor who took the x-ray and the patient returning to have the x-ray kind of explained to that person. What was interesting to me, I don't know, some people really know what to do with the jaw joint, and that's why we have 5 therapists at Primal Air. And his sino-nasal complex had the most important pieces of information. And those are that the mucosal thickening in the left maxillary sinus is depicted, moderate mucosal thickening in the ethmoid sinuses and the maxillary sinuses, and the frontal sinuses. The osteomeatal complexes were not patent. That means they were plugged. There was discontinuity of the floor of the left maxillary sinus near tooth number 14, where he had a root canal. Possible discontinuity in the floor of the right maxillary sinus near tooth number 2. I mean, it's just like on and on. His sinuses absolutely did not work. If I would have had the CBCT before we started onto our whole treatment plan, we would have probably stalled and we would have taken care of all of these sinus issues earlier, right? So this is, wait till you see what we found. Not only that, it says pharyngeal X recesses are detected and relatively symmetrical. The minimum airway clearance is approximately 247 millimeters squared, putting the patient in low probability of obstructive sleep apnea. That's according to beam readers. So, okay, if he has a low chance of having obstructive sleep apnea, what kind of apnea events is he having? So that's my number one question. We tried, so wearing the ring, he was having dips in his SpO2 during the day. And so he was very concerned about that. So we thought maybe just strengthening those muscles, respiratory muscles in the chest would be helpful. So he purchased one of these breathers and he really got a lot of kick out of it. Then we had to quit. We got this back from Advent Knows, and severe sleep apnea is still present. I don't have the original sleep apnea. So I think we did make a little bit of progress here between this October version and his original sleep study, which was in the spring of 24. So his average SpO2 is 93. So now I'm going to remember to tell you that SpO2s of under 97, we should make our eyebrows go up and wonder about diabetes and diabetes detection. Sleep apnea and diabetes are pretty closely related, and stopping breathing in your sleep is very detrimental to your red blood. It's very detrimental to everything, including the brain. So insulin resistance is part of the whole program when you're talking about sleep and sleep patients. Now, I know there are a lot of sleep coaches and all this other stuff, and I would feel awful if I was just a sleep coach and and that was with me as a dental hygienist too. We're sitting there treating periodontal disease and we don't even know if the patient has diabetes and that's why their gums are bleeding. This is a big, big deal. Diabetes and sleep apnea together is a huge deal. We do see too that some of these GLP-1 drugs are useful in reducing your diabetes expression, let's say, because you can lose weight. And there is another one that has been rated to be good at treating sleep apnea. So he's on that medication as well. So he's now lost 20 pounds, he said recently. He's 6 foot something, and he's lost a lot of this neck that he had here. And we started this non-ablative laser treatment for the soft palate before we had the CBCT. And when I showed the CBCT to the doctor who did that, that's not his treatment. That's the doctor that did the treatment, but this is not him. And she was like, wow, he doesn't need a mandibular advancement device, which is one of the things that Advent Knows was starting to talk about. So these are finally my x-rays that I had requested. And I do want to let you know that this is not a good position for a CBCT. If you are a practitioner, please don't use a chin rest and put the patient's head at a neutral, not even put it there, just have them relax. And then if their chin is this high, maybe there should be a note somewhere, but I know that he doesn't look up like this. His chin isn't this high. But look at his airway. You can see it's gigantic. The tongue still is not at the roof of his mouth. So that's a real puzzler. He's got a lot of things happening, and we've done a lot of things, and I'm surprised that it was still low. The the soft palate, this was pre-laser treatment. So, he had the x-ray and it took the doctor a while to get him. I mean, there was just a lot of stalling. This is why I really am adamant about creating this kaleidoscope of care program that we're doing. So all of us all talk together so that we don't have these missteps. I don't know if I would have even thought about doing the ablation, non-ablative laser treatment on this palate because it's pretty thick, but he's got plenty of room. When you look in his mouth, there's no room. Nothing is in there. So this is the right side, the left side image here. You can see that this is why he can't breathe. And this is probably why the tongue can't stay up against the roof of the mouth. And if you can see this root tip here, he's got a recurrent infection, and this tooth needed to be retreated because it's very likely that it was infecting this sinus, and that's probably a lot of the reason why he could never get it clear because it was just pumping, or I don't know, they were transferring bacteria back and forth. And when they do these surgeries, they don't take, I don't know, they don't do tests on whatever's up in there to see who's active in there. They just rip it all out. But this sinus here, you can see is, I don't know, beam readers called it thickened. I would just call it mucus. There was no way to get the mucus out from between the sinuses or up or down. And this tooth also needed to be retreated. And for all of the chiropractors in the room, I learned way after that these little tags right here, if you're not a chiropractor, these little tags that are coming off these cervical vertebrae are little tags of diabetes. So this guy was diabetic for a long time, a really long time. So these are the sleep reports that I get from the circle ring. And back in September, his average SpO2 was 3. So this was right after I took a course by Bob Walker at Exceptional Dental Courses on sleep and went a deep, deep dive into the physiology of sleep. And that's what alerted me to this low SpO2 being an indicator for type 2 diabetes. So what I liked about this too, and I don't know, sometimes the ring is a little bit wonky here. His ODI is 92, so it's still very, very severe. The ODI 3 is an index measuring the amount of times the oxygen level dips by 3%. And then this ODI 4 is by 4%. The ring did start to finally give us these numbers here. The time below 90% is also very telling. So here we are in December. So this was around the time of all the drama and all of the diabetes and all of the medication changes and the car accident and all of that kind of stuff. Oh, that was the other thing, beam readers. I don't know if you saw it while I was just kind of throwing my 2 cents in there. The pineal gland was also presenting as potentially calcified. So, all of these things. I mean, this kid is just ending up to be really in trouble. His SpO2 went into the 60s every night. Every night. His ODI was very, very high. So this was after he'd had the ablation, the non-ablative treatment. And here we can see the 90% column there. He's spending about an hour per night under 90% oxygenation. And then I was like, what am I even looking at with these? What can I make? What story can I tell with all of this information that I'm getting? And so, because I was like, okay, are we getting better? How is this telling me that we're getting better? We've got this incredible amount of time below 90%. We've got these ODIs that are super high. We've got these dips into the 60s for the SpO2. And this is just not acceptable to still have those high of a numbers. And you can't really see how they're changing because it's so slow. Myofunctional therapy is slow. So what I found here is that 3 dips into the red. There were 3 dips into the red across this night. And this was almost all in the green. This was almost all. So there were 3 times where there was no like bad results. And then this here was is in February already. So that was December. This is February. So we got him down to 1 hour, just 1 hour below 90%. And his ODI was 85, which is still really high. And he had his non-ablative therapy in here. And you can see 1, 2, 3, 4 decent segments where he wasn't into the red area. So, I'm like, okay, but his SpO2 is still 3 or 93. So this is still not responding very well. So he had his sinus surgery, and during the recovery time, the Excite OSA finally came in. And he was up to about 14 days, not sequentially, and the gadget will read how many times you skip, and then it gets mad and makes you start over. So that was a surprise. So now he's up to 21 days. I do not have updated photos, and I plan on taking them in his next appointment, which is in 2 weeks. So we had to make some, new recommendations. We were just bouncing all over the place with all of this new information. He had a very long recovery with that sinus surgery. And right after the surgery, his time under 90% was down to about 30 minutes, which isn't great, but I mean, compared to the other days, it does seem like things were working. And then the swelling came back. Sorry. He had the root canal retreated. They did not use ozone. He had a rough recovery. And 4 weeks after the surgery, I called him back in for ozone treatment because he was back to 90 minutes under 90%. And I was like, this is nuts. Why do I know that? And why does the ENT with a million years of education and the ability to do sinus surgery on people in the office, why isn't that guy monitoring the sleep like this? And I don't have a relationship with Advent Nose, so a little funny sending them a letter saying, wake up, you guys. This guy is still dying every night. So he's still in a very long treatment plan. I was at the Holistic Dental Conference and I spoke with one of the premier dental ozone teachers about his sinus condition. And he suggested that I put about 10 cc's of ozone gas into each nostril using a barrel syringe with no needle and leave it in for about 30 seconds twice. And I called him back in 2 days for another treatment plan or another application. And he said, I don't think it did anything. So I really, really want to try this bongo. And so he took the bongo home and he's been doing really well with that. He wore it for about half the night, that first night, and I was very, very, very excited to take a look at his readings. And his time went from 90 minutes. You can see in the second line, it was an hour and a half. And then the third line down, it was, an hour and a half plus, an hour and 3/4, really, down to an hour. So that was awesome. His SpO2 went from 100 without the bongo, and after the surgery, I still like a month after the surgery, and it still was 186, and that part didn't change all that much, which is why I'm not a fan of that number. People want to see some change, and so do I. So the under 90% is my favorite number. So he said he took it off at about 4:30, and then we can see that things went down. So he seems to be in heaven with this last. I hope it's the last thing we have to do. He's still using the Excite OSA. So the OMT has been at work. He's pretty diligent about it. Um, the CBCT was finally done. The night laser or non-ablative laser treatment was done. He's working with the OSA, the Excite OSA. But due to the tongue tie and the narrowness of the palate, he's a geneticist, so he's got a lot of scientific training. And a lot of these science people do not believe in chiropractors or the fact that you can manipulate skull bones, the bones of the skull, that they believe them to be fixed, and that's not really true. So anyway, he's resisting that. So that could be the last little thing. He was diagnosed and is being treated for type 2 diabetes. He is still on the weight loss injections, and the carotid plaques stimulated a recommendation for cardiac heart scan, which he has not done yet. He's got to go to work, and this is all taking a lot of time. And the continuous sinus junk prompted an Advent nose assessment and treatment with. So that's where we are right now. We're still going along on our treatment plan. We have some pretty good conversations about different things that are going on with him and his wish to have good health and to not have to be so tired and not have to worry so much about all of these different things. I did also recommend early on, which I didn't put down in here, that he might want to try an all meat diet for a time. And he just thought that was interesting. But most people are just so indoctrinated with the plant food part that it's just too gone. It's just too over the top. So thank you for listening. I hope you gained something from it, and I hope to hear from you. And if you'd like to make an appointment for this kind of care for your sleep problems, you can contact us at primalair.com or call our office at 608-318-2800. And we'll see what we can do about helping you solve multiple problems as they coalesce into one major problem. Have a great rest of your day. Sinus surgery. So that's where we're at right now.